Hi, everyone, and welcome to this second webinar of our series. So last month, we discussed the data on the characterization and treatment of Kwashiorkor. This month, we're really thrilled. We have around 220 people registered to join our discussion, and it will be on the latest research on the overt signs of Kwashiorkor. There will be another webinar next month. We will talk about it at the end. And in this one, we will discuss the metabolic and physical changes associated with Kwashiorkor. This webinar today is part of a series where we are revisiting all the evidence on Kwashiorkor malnutrition. It's organized by an informal group that communicates and discusses their research for peer advice. I put this group together following the project putting Kwashiorkor on the map that was published in 2016. If you don't know about it, I would invite you to look for it. It's easy to find it when you Google it. And if you are interested in learning more about this group because you are a researcher or practitioner working on Kwashiorkor, please get in touch with me at the end of the session. We will share my contact info at the end of the webinar. Next slide, please. Just a few housekeeping items before we get into the discussion. This webinar is scheduled for 1 hour and we will end on or before that. We're really looking forward to you being engaged and participative. So for that, because we are quite a lot of people, we will use a chat function so that you can participate and ask questions as they come to your mind. So if you're not familiar with WebEx, on the bottom right of your screen, you should see several buttons. You click on the white one with the blue chat icon. That opens the chat box on the bottom right of your screen. Then once you have this, you can send questions at any point. You can start now if you want, but please direct your questions to me, Alexandra. I will gather them up to ask all of them at the end of the question. Well, I'll try to ask all of them. It will depend how many we have. Next slide, please. And so by way of introduction, I'm Alexandra Rutishauser-Perera. I'm the head of nutrition for Action Against Hunger UK, and I will moderate today's discussion. I am joined by Mary Fitzpatrick of the Feinstein International Center, Tufts University, Sofine Heilskov from Aarhus University Hospital, Kirrily de Polnay from Médecins Sans Frontières, and Regina with the University of Westminster. So now I'm going to turn it over to Mary first to begin with a brief summary of our topic for today.
Thanks, Alexandra. It's a pleasure to be here today. Today we're going to focus on the overt signs of Kwashiorkor. Sorry, I'm running both the slides and speaking here. Most of us are familiar with the signs of Kwashiorkor, the overt signs of Kwashiorkor. Most of us on this webinar are familiar with these. Today, we'd like to discuss some of the subtleties in two of these signs that are often missed, and to remind ourselves of the signs of others, not just edema. Maybe because it's the diagnostic, but we tend to document edema and completely neglect the other signs of Kwashiorkor. One of the difficulties is that edema, other than edema, these various other signs are not always present, and they may not always be obvious. This is why edema was originally selected as the cause or the diagnostic for Kwashiorkor. But these other signs, they still can provide us with clues. Even when we do recognize a particular sign like edema and skin lesion, we don't always look into their variations. As Andre Briand pointed out in our last webinar, early research on Kwashiorkor was mostly community-based, but it's now more clinic-based with very little done in the community. clinic-based research compares cases versus non-cases and classified bilateral pitting edema in the feet. So there's little opportunity to observe how Kwashiorkor progresses. Mothers and practitioners and other researchers that do work within the community, they report that some signs appear before others, and that the signs themselves progress through a certain pattern. We might say that some of these signs are early Kwashiorkor, or they are less severe Kwashiorkor. And these would include like lethargy, irritability, appetite changes, as well as a facial edema around the eyes and cheeks. Some of the later signs would be the edema and the skin changes. Hair changes, it kind of depends on whether Kwashiorkor is progressing rapidly or if it's progressing slowly. Within each of these signs, though, there's often subtleties that we miss. And our panelists today are going to talk about some of these subtleties and what they mean. So if bipedal pitting edema is the diagnostic, why is it important then to learn about these other signs? First, the edema is a late sign. This comes when a child's already severely malnourished. Just with wasting, we have a duty to really try to treat these children before they reach the severely malnourished state and they're at higher risk of death. We also currently treat Kwashiorkor as a binary. It's either they have Kwashiorkor or they don't. But mothers with children in endemic areas can easily tell us certain signs that indicate to them that there is that the child is descending into Kwashiorkor. So if there's high rates of SAM in a community, especially if a high proportion of that is Kwashiorkor, we could be underestimating the burden of malnutrition in an area. And if we make cases in research, we compare cases with non-cases. And if we're determining that solely by whether or not they have edema, rather than these other signs that may indicate a more moderate version of Kwashiorkor, then we may be classifying some children as not malnourished who really are somewhat malnourished. This then is a misclassification. It can lead us to some erroneous conclusions about what is or isn't the cause or progression in Kwashiorkor. If we have one takeaway from this webinar, we want you to leave with a better appreciation for the importance of this full array of signs and the variation of signs within them, and the effect that this can have on our research and protocols. Now, I'll pass you back over to Alexandra.
Thanks again, Mary, for this really good introduction. So I'll pass it over to Sofine now, who will tell us more about skin changes.
I will. Thank you. And thank you for having this webinar. So I would like to emphasize what Mary pointed out, that we're here to encourage researchers to investigate in the clinical science beyond edema in hope of finding new insights to the mechanisms behind Kwashiorkor and ultimately find new ways to improve the treatment protocol, maybe even personalize treatment a little bit. So this is where I think the skin changes could come in handy. Next slide, please. So in this talk, I'll introduce you to the skin changes in severe acute malnutrition, and I will present what we know about the skin changes in Kwashiorkor as it is today. I am afraid to say that I might disappoint you because Kwashiorkor specific skin changes are, in my opinion, not supported by solid data yet. That is, we know a lot and still we know nothing. which leads me to the second bullet point, the work on a standardized scoring system for the skin lesions, and a brief introduction to the ScoreDoc tool for scoring skin lesions in severe acute malnutrition. And I think this subject may be the most important of today. I'll briefly tell you what we know on which skin changes affect outcome, and maybe I'll put in some focus areas for interested researchers. Next slide, please. So, historically, skin changes in famine has been mentioned for as long as the edema has. Cicely Williams described the skin changes as an important clinical feature in her characterization of Kwashiorkor back in 1933. And as you can see on this busy table, many authors have later characterized skin lesions, all using their own terminology. And a point here is that when these important descriptions are then not supported by good footage, it is impossible for us to be sure that we're not comparing oranges with apples, if I should use a term from the first webinar. But to get back to what we do know, Cicely Williams and also Vasanta, they took good photos of their cases. And I'd like to show you some pictures from my research of skin changes in edema, similar to those documented by Cicely Williams. Yeah. So none of the non-edematous patients I've seen had such a severe grade of lignite skin changes combined with bullae erosion and desquamation as you see here. So the question is, are these then the Kwashiorkor specific skin changes? And I'll get back with my answer to this in a moment. Because this brings me to the most important topic of this talk, actually. How can we answer questions on skin when we do not have a common language for describing the skin changes and when we cannot compare studies? So if we are to do this, we need to characterize skin changes and then look at their connection to the features of Kwashiorkor. Next slide, please. So I did a characteristic on a Ugandan cohort of 120 children below 5 years of age, all with severe acute malnutrition, both edematous and non-edematous patients. And we defined 5 skin changes that were characteristic in our cohort, all of them not comparable to the classical clinical signs of single nutrient deficiencies. So you see the 5 signs here on this slide. What is shown is also just a brief introduction to the ScoreDoc tool, which is basically a thorough description of the 5 skin changes using dermatological terminology, and also an instruction on how to grade these, all supported by clinical footage. So this tool can be retrieved from the publication of ScoreDoc from 2015 or from the Handbook of Famine, Starvation, and Nutrient Deprivation. So now that we have this system for characterizing the skin, we can go back to the question, what are the skin changes of Kwashiorkor? Next slide, please. So here edema is used as an indicator of Kwashiorkor, and we see how the 5 signs are distributed in our cohort. Out of the 5 skin changes, only stages of bullae erosion and desquamation were specific to the edematous patients. Next slide, please. So for now, it looks like that these are our Kwashiorkor skin signs. Our next question was then, are skin lesions dangerous, and what skin lesions are dangerous? Next slide, please. So patients with lignite skin changes on admission had a significantly lower chance of survival compared to unaffected children. The hazard ratio increased with the grade of exposure using the ScoreDoc tool. In a regression model, including gender, edema, and a grade 2 to 3 stage of lignite skin changes, those are the worst grades, we assessed the admission risk of dying during hospitalization, and we could predict death with a misclassification error of 12.6. So I'm not saying that this is like a perfect model to use in the clinic, but it emphasizes the value of a skin assessment in a quick triage or in a risk assessment. Next slide, please. So for future studies, focus on the skin changes that affect outcome, like the lignite skin changes. I suggest to include stages of bulla erosion and deformation too, since these showed a tendency to lower survival in my cohort. Use the ScoreDoc tool in your research to connect the skin changes to clinical conditions that are not easily assessed in a low resource setting, and to ensure comparability across studies. In the first web, André mentioned the need for controlled clinical trials, and I could suggest a topical zinc intervention with a reference to golden and golden. This said, I think an intervention where the mother is giving just a piece of soap on admission to keep her child clean and the cloth clean could be an interesting intervention too. And also looking at essential fatty acids levels could be interesting in relation to a skin score. Next slide, please. And so just to wrap it up, I'm convinced that we will not get any further in our investigation of the skin if we do not agree on a common terminology and a common protocol for documenting the skin lesions. And I recommend using a proper photo protocol for the documentation. This is essential when it comes to skin. And Brian Gonzalez mentioned the need for a global overview of the characteristics in Kwashiorkor to better understand the nature of the condition. And I must say that I agree with him on this. Next slide. These are my take-home messages, and these are my references. Thank you.
Thanks again, Sofine. And I want to remind everyone that we will share the recording of this presentation afterwards, so you will have the presentations with the references. So over to you now, Regina. Thanks.
Thanks very much, everyone. So first of all, welcome everyone that's coming to join us today. A little bit sort of an added note to Mary's point. The work that we've been doing has been actually very much clinical, but with community. So we've been doing an awful lot of our Ethiopian and East African research into Kwashiorkor, working with community health workers and community volunteers. So it's slightly a little bit different than the clinical predominance there, some of the research that you might be hearing from the others in today's talk. That being said, as a nurse midwife, I've been working with malnutrition since the 80s. And as Andre will say, we've definitely moved forward, which is brilliant, from the days when we used to have to make up feeds and try and look at nutrition units with volunteers. So having stabilization units and the treatment and larger programs have certainly progressed severe acute malnutrition, specifically odematous, in the last sort of decade. I suppose, like many of you on this call today, you're here because we're still kind of frustrated that we still don't know a lot of things. So a lot of my talk is really what we don't know as much as what we do know. Next slide, please. So as certainly, as Alexandra talked about, there has been a little bit of progress. So Nikki's on the call, Nikki Dent and others who worked hard to start beginning to put Kwashiorkor on the map, looking at where do we have the burden of disease, where is the places where we see a lot more Kwashiorkor. And this sort of really challenging thing, which many of us are frustrated by, is that we still have a real problem with knowing exactly where all of our Kwashiorkor are. We do know in places like, for example, Malawi, about 50% of the severe acute malnourished children would be Kwashiorkor, and DRC is very high levels as well, up to 32%. On the other side of Asia, Pakistan might be 1.7%. However, even these figures, Ethiopia on that report didn't come up with a high percentage level. Yet our research is showing between 45 and 50% of Kwashiorkor admissions into that. So it depends really on who's putting forward the reports. And so a lot of the problems that we have in placing Kwashiorkor on the map are the fact that we do not have adequate data sources. They're not collected in all of our district health services. Edema is not always picked up. So even though, as was mentioned about the skin changes by Sofine, which would be an added valuable point to be picking up skin changes, I think there is still, we're missing people even with edema. So this is a challenge. Next slide, please. So one of our areas, and today is really about trying to excite more of you and get, like, the fact that Alexandra has put this group together. It has been talked about by many of us for a while, but we do need lots more people to come in. There's so many questions we still don't know. So even the whole idea of what is the pathophysiology of edema, you know, for a long time, and it's something that many people will hear me talk about. It kept getting termed as protein energy malnutrition, and it's something that I think we need to be a bit more specific on what is the actual causes of edema, because if we had a better idea of the causes, then we will be able to put treatment protocols into better implementation at a district and at a community level. So obviously there is, if people are not eating well, there is an issue about the fact that there isn't enough protein. There is the hypoalbumin in the blood cells, but we know that that's not the only reason. So why is this happening? Is it about, you know, salt and water balances? I really, if you are interested in this area, I really would advocate that you do read Andre's paper on the enigma, is Kwashiorkor is still an enigma, because it does put you out all of the research that we have on this area, and it shows that we still don't know the answers to many of these issues. Some of the most interesting things and some of the causes are, is it about oxidative stress? And is there a kidney involvement in it? Is there a dysfunction in the kidney? So is there some populations you might find that if they are living in a situation where there is malnutrition or chronic malnutrition, are they not adapting to that situation well? And this is increasing amounts of interest is looking around the role of the gut and the gut microbe. And it would certainly be something that even how we deliver patients, talking even to mothers, as Sofine was saying, talking to mothers at the clinics, the perception is that even practices of delivery, how they've changed, and the addition of giving certain things like cow's milk at a clinic or added milk has led to differences in the amount that they're seeing higher levels of Kwashiorkor. So looking at the gut microbe and as a causal factor of the edema. The other issue that has been coming up is about the role of sulfur amino acids. And this would be interesting, again, looking at the issues that Sofine talked about with skin changes, because obviously sulfur is also, the skin has a lot of the skin involvement, could look to the lack of either the lack of absorption of sulfur amino acids or the lack of intake of amino acids through the sulfur. So again, it's another area which we could do a lot more research in. Another interesting avenue around the role of selenium. Selenium, we're doing a lot more research globally on looking at its role in things like depression, but is there a role for selenium in absorption? The other thing that is coming up, which is a link to our research, is endotoxins. There's been a lot of talk and research looking into aflatoxins. If you don't know what that is, aflatoxins are funguses that we would find on grains if they're left out in many of the places where that have a large amount of Kwashiorkor are places that are based on staples that are predisposing to aflatoxins. But even with that research, again, if you're reading Andre's paper, a lot of that has been disproven, or at least not, there's not enough research on it to come up with that. So some of my research, I'm going to go to the next slide, please. The research that we found, a lot of these ones are the challenge with coming up some of these out. So the endotoxins, I want to just start with that one first. So some of the toxins we don't understand as climate change is leading to changes we're finding in Ethiopia. Some of the big changes was that the foodstuffs that were being eaten by some of the populations with higher levels of Kwashiorkor had major changes in their diet in relation to what they were eating. There was very little, if anything, other than a carbohydrate. Many things, like there was a thing called false banana, which was something that they used to wrap in banana leaves, but then they wrapped it in plastic bags. And so is there a toxin coming out of that? So there's a lot of things that are very much that we need to do more research in. The other thing that we're finding out, even though there has been a lot of talk about edema being a causative, someone's been able to diagnose edema if it's 1+ for pitting edema in your feet, and it goes up to 2+, 3+ is the more extensive edema. We're finding that health workers, especially community health workers with little amount of training, are not actually checking for edema, never mind referring that in something like half of the surveys looked at in Ethiopia, all of the ones who were referred had the same amount of edema, which again, when the patients were checked, was not the same. So they were all diagnosed as having 2 pluses of edema, when in actual half the patients had 3 pluses of edema. So there was a misclassification of edema even, never mind the skin changes. The other thing that we were coming up with very serious complications was that if these children were admitted at night into a hospital, sometimes they were misdiagnosed as having congestive cardiac failure, and they were given Lasix, leading to higher levels of mortality with these patients. So again, even if we had added what Sofine said about adding the skin change aspect to the diagnosis so that we could help avoid some of the misdiagnoses at the onset of having a child who was seriously ill. The other problem is that in the community level that we found, in the community when they were going for their nutritional assessment, most of the children were not having the clothes removed, so they were just taking the walk tape assessments without looking at the legs, without looking at the rest of them. There was a lot of comorbidities of scabies, and if we're talking with the parents and the fathers, the scabies area, so the hands and the feet were actually swollen and scabbed, and the parents were saying that the scabies was something that they were increasingly worried about because it was infected. Equally, the hospital didn't have any clinical treatment. There was no treatment left for either of these, so there was a misperception of what the problem was. They were attending the clinic for scabies treatment when actually their children were Kwashiorkor, and they were being missed, and there was an increased fatality within those groups. The other problem was that there was no mortality audit. So people who were dying of Kwashiorkor, when they were getting to the stabilization unit too late, there wasn't a mortality audit being done. So I think there is something that we could do if we're combining what Sofine was talking about, maybe having a triage system. We used to use a triage system quite a lot, but as we are having more and more community health workers that are given more and more roles, that we're finding that their ability to retain all of the information. One of the research we've shown is that for a community health worker to retain all of the nutritional assessment roles that they're given, they have to have 9 years of formal education, and that's certainly not what we have. Most of those are not having that. So there was a big dichotomy about what was expected of the people that were doing the
Sorry, I think just lost Regina, unless it's just me.
Yes, it looks like we lost her. Should we move on to?
Yes, I think we'll move on to Kirrily and then catch up with Regina with the Q&A, I think. So Kirrily, I'll give you the floor. We will get on your slide.
Okay, hello everybody, welcome. I think something that hits me and why I'm so glad we're doing this webinar is how much we know and how much we don't know. For me, for example, I've never seen the moon face that the early Kwashiorkor signs that Mary's talked to us about, but my experience has all been in health centers and hospitals. I've never seen these licheniform versions of or presentations in the Kwashiorkor skin that Sofine has said, but again, that's an early sign. Maybe I'm only seeing them late. So I think there's still so much we have to learn on this topic. So I'm going to be talking a bit about treatment today. And one of the reasons that I wanted to talk is also in case there's some wonderful new evidence out there which wants to contribute or help us adapt this treatment protocol. So if you go to the next slide, please. As we've all talked about, we're treating something we don't really know the cause of. But as we also know, this is nothing new in humanitarian medicine when we often take a syndromic approach. But first, we have to do no harm. And my fear is that we've often done harm with these skin lesions. This is one of my patients from 2012, I think, Sierra Leone. And I think as Sofine had alluded to, you see this little boy and everybody who's worked with Kwash kids is thinking this one isn't going to do well. And he didn't. And it's really often the skin, which is that real trigger for you, where you think, oof, this is not good. And then I would say something again next, which is that as doctors, I've debrided hundreds of wounds and I've sutured hundreds of wounds, but I never really learned in my training about wound care after I'd finished suturing. And I think that's something amazing in working in these sort of contexts, is that doctors do learn the useful nursing skills. I learned how to make up ceftriaxone and all these things, but it means that you also need a multidisciplinary group to come up with these treatment protocols. And really all the credit for this wound protocol and the approach we take in MSF comes from my incredible nursing colleagues. So next slide, please. So just having a quick look at the existing guidance, which is the same really from the 1999 manual and the pocketbook of 2013. And, you know, everybody does their best at every stage to try and create guidelines. The problem we see with some of these products is there's very hard to ensure any kind of sterility or even hygiene with the use of some of these products. And then interesting things like gentian violet and these potassium permanganate baths, which I think didn't ever look like this beautiful picture here of this bath, was that they would really dry up these lesions. And sometimes that made people feel better to see these dried lesions, but we don't know the etiology of the exudates to know if that's the right thing to do to dry them up. And we were seeing often these crusts and thinking, oh, that looks like it's getting better, but we couldn't see what was going on underneath. And this is what I really learned from my nursing colleagues. That's the really important thing, is to know what's happening in these wounds. And we're talking about them as wounds because we kind of don't have, as Sofine says, we don't really have some other language. So talking about them as wounds at least help us to work with the treatment. And then just one other point I'll make, because I don't want this to be too technical detail, is the use of iodine. And I'm sure so many of you have seen this, the absolute misuse of iodine. And you see all these bottles here in this picture, and basically I've seen almost all of that being used for one patient. So we really saw this was being used far too much for children with Kwashiorkor lesions, and there is a massive risk of systemic absorption. So that's also why we've really tried to reduce it. So next slide, please. So as I said, it was my amazing colleague Andres Marelli in MSF based in Brussels, who decided to, he's done a whole wound care protocol for MSF for general wounds, but he decided to tackle quash lesions as well. And so what we decided, looking at all the evidence we had, speaking to all the experts we had, the dermatology experts, the wound care experts, the people who hadn't seen any quash lesions, and the people who'd seen lots of quash lesions but weren't experts, and the other was trying to bring this together. And actually we realized that the best way of doing no harm was to have this holistic approach to wound care. So that meant that we really tried to focus on wound cleansing, and that we've tried to really restrict the use of antiseptics. So we're saying, like, stop slathering iodine everywhere, and that there's this huge importance of having a moist environment, but a really well-balanced environment. And again, to teach people how to assess that. So in these protocols we've used, which I can share, even though obviously they are very internal MSF protocols, but happy to share. And then the importance of the documentation. Again, as Sofine says, if we haven't really classified what we're looking at, it's hard to then see the improvement. So that's why the documentation is important. Next slide, please. And then something we've all been talking about is the subtleties, the small areas that we have to take note of, to really focus on the important aspects around the lesions, i.e. the patient. So you can see from this, the top picture here, he's on a nice clean sheet, a nice clean Inco pad. And then you can see the bottom pictures when I walked into one of our wards in Nigeria and I saw this plastic sheet, first thing to do is pull that plastic sheet away. So really looking around the environment of the child. Are they sitting on a dirty urine-soaked lapper? Can we have a clean sheet? How can we help to have this holistic approach? There was lovely Rosalie Bartels, who's a doctor who worked a long time in Malawi, and she was telling me about this amazing thing they did of having these little bed frames, so a little frame that could go over the patient. So once you've done the treatment, you could put that so that it wouldn't touch the skin, but you keep them warm. So I think these are the wonderful, innovative approaches we have to try. And then the advice on when to use antibiotics. The existing guidance was systematic antibiotics, which is never clear if that's, you mean amoxicillin as part of the general systematic treatment for malnourished children, or antibiotics on top of that, and also not which ones. So we've also tried to be very clear about when you need to give antibiotics and when not to. And then my final point is the pain relief. And I'm sure so many of you can really remember times you've seen children having dressing changes done when you think, I know that in Europe or in the UK where I was trained, they'd be in theatre for that. So we're really trying to, and there is such a resistance for using analgesics in malnourished children because of fear of problems of hepatic metabolism, renal metabolism. Please do not hold back from appropriate pain relief for these children. And I'm quick to go to very short, small doses of morphine to do that. So please never forget pain. Next slide, please. So just the challenges of this have been what everybody been talking about, very heterogeneous evidence to know what's the best thing to do. Obviously, we need to balance the ideal protocol on our field realities. This tent is what a lot of our places, our wards look like. So having to make sure that we can do beautiful dressing changes in this environment has been a challenge. Next slide. I do want to finish on one positive note, because it's one of my favorite patients of all times. But I think, again, this shows us the wider issues of Kwash. So this is my little fatty on the left. And this was her after many, many weeks. And then we eventually, of course, rescreened her for the third time about TB, and we found a TB contact. And then the picture on the left is 2 weeks after TB treatment. So again, never forget the comorbidities, never forget TB and HIV, as all these things are really fitting in together to impact the picture of Kwashiorkor. So thank you very much for your time, and I'll pass back to Alex.
Thanks a lot, Kirrily, and to all the panelists. So we've lost Regina for a final slide. We're not going to go back to the slides, Mary, but I will, before starting the Q&A, I will actually have a question for Regina that would summarize our last two slides. So Regina, basically, with all you've said before, what areas of research would you prioritize for edemas, which is basically what your last slides were about? Thanks.
Okay, so just again, sorry about the losing control or the voice. So what I was saying was basically looking at testing probiotics or looking at the gut microbia, doing some more research on that, looking at does repeated infections in the first year of life impact on edema. So for found that there was a correlation between sort of water and sanitation with these children, as was just said. So does repeat infections with treatment with sort of, say, Septin or something in the first year of life change the number of children that have Kwashiorkor versus marasmus? Looking at trials to test optimizing, looking at the sulfur amino acid intake. There has been that cysteine supplementation, which we talked about and Andreas put into his paper. Looking at clinical studies to look at the relationship between the MUOC scores, mortality, response to treatment, and how edema is responding to that. Looking at the degree of edema in relation to the prognosis for Kwashiorkor, and then trying to ensure that we are getting better at assessing the incidence rather than just the prevalence, but that we have a better map of where this is happening in relation to real-time diet and recognition. Thanks, Alex.
Thanks a lot, Regina, and hope we're keeping you till the end to answer the questions. So thanks again. I already have quite a lot of people who ask a question, and thanks for that. I will try to address them all, even if I can't promise anything, because we are more than 100 people on the call, but please continue addressing them to me. So I will start with two questions in one for you, Sofine, which is about the skin scoring. So there was a question that says that in addition to the reviewed literature, were certified wound care specialists consulted in developing the ScoreDoc scoring system? And if not, is there a plan to cross-validate with existing clinical tools that are used in the wound care profession? And then another question that was asking if the skin scoring system was validated among other cohorts. So if I can let you answer that, Sofine, thanks.
Yes, of course. So first, the development of the ScoreDoc tool was done in association with the dermatologists from Denmark. And in Denmark, wound care is performed at the Department of Dermatology too. So the two specialists in dermatology from Denmark do also know about treatment of wounds. Those two I participated with or developed the score with. They are not specialists in wound care, but they know about wound care. So to answer the last part of the question, if there's a plan to cross-validate with existing clinical tools for wound care, this would be a very good idea, or at least a collaboration with the project presented by Kirrily, for instance, could be very interesting to further develop the ScoreDoc tool. But as it is now, the ScoreDoc tool is only registering a tool for registering and scoring skin changes, not for treatment yet. So this is to further to be developed. And regarding the last question, if it is being validated, if there is a plan for validation of this the ScoreDoc tool, I know that there is a team who is validating the ScoreDoc tool as we speak. I think they are done collecting their data, and now they will, and I hope they are attending today, of course. So I hope we will hear from them and hear what they find, if they find the same. But what is important here is that this validation is being done in a sub-Saharan country, and I know that from speaking to other researchers and collaborating with other researchers, also in other regions, that it varies a lot, the clinical presentation of the skin. So in some regions, they do not even see skin changes, the severe kind of skin lesions like lignite skin changes and Boolean erosions. So it needs to be validated in other countries too, other than sub-Saharan countries. And I think this is important to make it more generalized and to make it into a tool that we can use on a global level. Thank you. I hope this was enough.
Thanks a lot, Sofine. And just so you know, for the question that will not be addressed, we will share them with your names as well with all the panelists, and we'll try to answer afterwards. So do not worry if your question was not addressed. I have a question for Kirrily, and I can help if you want, because it's things that we discuss often together in meetings as well, Kirrily. So it's regarding the availability of data that is flagged as a key barrier to mapping Kwashiorkor. What changes do you think should be incorporated into, I mean, examples were given, a mixed DHS or SMART, but basically any nutrition information system to better detect cases. For example, do you think that we should use something like ScoreDoc?
I think ScoreDoc is fantastic, the work it started. I think we still have to be very careful with what we promoted at this sort of national level. And I think also we have to think about who does these surveys, especially like the DHS, for example. I mean, SMART, sometimes you have people with more nutrition experience, but especially from these more national surveys, for me at the moment, if I'm completely honest, I wouldn't be going further than Edema. But I think if we had, if we can all get everybody to do a bit more research, we can validate some of these scoring systems for sure, then we could think of adding extra signs, clinical signs. But for now, as it stands, I have to say I probably wouldn't go for anything more than Edema.
Thanks, Kirrily. And I would reiterate also on that. I think we still have a long way to go about how edemas are also diagnosed right in surveys and how they are often missed. And right now there is a big development of family MUACs to diagnose malnutrition, which is absolutely great because we are going closer and closer to the children. But one of the things that we've seen with all the evidence gathered is that very often edemas are forgotten by the families, even though it should be family MUAC and edemas. And so more importantly right now, it's also about making sure that children with Kwashiorkor are not forgotten and overlooked when we look at the burden of acute malnutrition, which is still often the case. I have another question actually for Kirrily. It's quite clinical. Should we be considering the skin lesions closer to burns and increase consideration to clean treatment areas rather than on the bed? I'm not exactly sure what it means.
Yes, absolutely. I mean, that was something I didn't really mention, is that's one of the key approaches that that my colleagues really decided on. I mean, I keep saying our colleagues because although I inputted it, wasn't really me who did the heavy work on this, was that actually treating them like burns was exactly, well, not exactly, it was probably the closest we could get at the moment to an approach which makes sense. And that has helped us. And something I didn't mention as well is that we have tried to, well, we've implemented this protocol because it's part of the standard MSF1 now. We've implemented in quite a few projects. We've done some very small operational research into, first of all, the ease of implementing this. And we really found that talking to people as if telling the staff that to treat it as a burn actually really helped us. Because it just gave a bit of a focus. And then hopefully the next stage of research for us will be seeing if this new protocol improves outcomes. But again, as Sofine said, we'll need to be able to really score that to know. So yes, definitely treat as burns for now.
Thanks a lot for that. I have a question maybe for you, Regina, if you can hear us and talk. Is Kwashiorkor ever considered in adults, especially in the elderly? Is it something that you've ever heard about, noticed? And others can also.
Yeah, I mean, as I said, yeah, I think others might. So certainly in our work in Africa, it hasn't. We think that the situation has really not been. We haven't had that group of population in the clinic. It's hard enough to get the young children into the clinic. So I think that maybe others, I don't know, maybe if Kirrily has had, certainly in Somalia and South Sudan, we have had severe acute malnutrition in the marasmus, but not so much in the Kwashiorkor. So I don't know if Kirrily has seen that at all.
I think the problem for me, the problem with adults is that there's so many other reasons for them to have this bilateral edema, and for it to start in the kind of same way. So personally, I don't think I've seen it. I haven't been in nutrition situations which have been so bad that adults have been affected to the point where I probably have seen them. And when I think about all the adults I've seen in like refugee camps, there's so often another reason which is probably more plausible: heart failure, you know, all sorts of cardiac conditions, all sorts of. So I think that's quite hard to see. But I do remember like the really early work by Steve Collins that he did was a lot more about adult malnutrition, and so I should probably look at that. But Mary, I'll let you answer that. I think you have something to add to it.
Yes, I have seen it in famine conditions. Am I on? Yeah, I have seen it in famine conditions, like in the Congo during the war there. It actually was not that unusual. Certainly it was more frequent amongst children, but women, especially women that were lactating, or women that were severely deprived of food and extreme food insecurity, we did see quite a bit of adults and some adolescents in the Congo, in even now in areas where there's extreme food insecurity. We'll see it in children up to like 10 years old, so it's not just the youngest children. But the surveys generally stop. Either they just do to 24 months or they only do to 59 months, or 5 years old. So we don't really get good data on the prevalence amongst adults.
Thanks a lot, Mary. I will keep you on the line because I just got a question that I think you'll be very interested about. It's about the other psychological and behavioral changes in Kwashiorkor that would be good to look into in terms of early diagnostic or classification, but also in how we can support the children with these symptoms. And I know it's something that we discussed in preparation of this webinar, so maybe you can answer that point.
Yeah, this is a This is a difficult one because there's so many different things that can affect a child's behavior. But parents do report as one of the earlier signs, and one of the signs that they know that the child is becoming malnourished, they'll say, is that their behavior changes. They'll become lethargic, they'll become irritable, and really the pictures that you see of the kids, it's rare to find one that's smiling or moving around, and they see this as one of the earlier signs. It's really hard to quantify something like that, but it is something that maybe we can take note of, both in our research, as a sign that kind of goes along and corroborates with the other signs. But it's something to also consider with the child himself. If he's feeling just like with the wound care, it's not just the health of the child, but the pain. You want to manage the pain. If a child is feeling very anxious or very lethargic and depressed, I think we need to consider that with the child, and how we care for the child, and how we extend to the child. I don't know if I answered that question well.
Thanks, Mary. No, that's fine.
Just can I,
yeah,
Alexandra,
yeah,
just to come in. So one of the researchers, and I don't know if Andre, I know, is on, so I don't know if he has come into this research, but one of the factors of one of the research projects that came in on this was looking at the reason for the crying, the sort of the really typical apathetic, but really that horror, the Kwashiorkor cry, and it was the eating away of the myelin sheath. So in other words, the children were in severe pain. So coming back into the Kirrily issue, and again, I don't know if Andre has seen this research, but again, I think that is another area. So not just the behavioral changes, but actually what was the physiological changes that were leading to them to be in more pain as they were eating around the protein around that they were eating for energy around the myelin sheath was one. Actually, they were actually in real pain, and that was different to the marasmic child. So again, I don't know if anyone, but that would certainly be another area that I think that we should be looking into.
Thanks a lot, Regina. I have another question for Sofine regarding the skin changes. And if you could please, Sofine, clarify what are the exact features of the lichenoid? I'm not sure I'm pronouncing it right. The lichenoid skin changes. The person who asked said that it's not generally reported as characteristic of Kwashiorkor, and that in Jamaica they tend to see very intense pavement dermatosis in children with Kwashiorkor.
Okay, yes, of course. So I think maybe the reason why they see crazy pavement dermatosis in Jamaica is because this is the term that has been used through time. So lignoid skin changes is a dermatological term, and therefore not often used by researchers in developing countries, because it's often not a dermatologist who's performing the research. So the reason why I'm introducing lignoid skin changes is because this is a term that can be used, and by saying this, a dermatologist would know exactly how it looks in the clinic. And this is also why I would like for researchers to use this term and know lignoid skin changes. So maybe we could put up a slide. I sent a slide with the lignoid skin changes, so the person who asked this question could actually see from the tool the lignoid skin changes. Yeah, next. So these are the extra slides I sent to you in the very end. Okay, so we have it here too, lignoid skin changes, but it's very small. But if you do not have the enlarged version, I can just tell you. So it's like lignoid skin changes are actually what I see as the parallel to the the skin changes originally, yes, here they are, thank you, originally described by Cicely Williams, because the development, or at least how it's spread on the body is much like what was described by Cicely Williams. And she was one of the only researchers who could actually describe the development of the skin changes, because her patients were not treated professionally as today. So the skin changes of her patients could actually develop while she was observing them, in contrast to my patients who actually got better immediately when they were admitted. So I could not see the development. So what is seen here are the lignoid skin changes, and they start as these small papules, and then they develop often on the extremities, on the extensor sides, and on the buttocks and in the inguinal area. And they would sort of coalesce into plaques. And in the end, in the grade 3, what is seen here, they can shed off and leave erosions and fissures. So I don't know if this answers the question, but or if it's helpful for the one who asked the question to see this, and if it fits with the crazy pavement they have seen.
Alex, can I just say something quickly as well? I think it's really interesting, this question as well, because yeah, like I said, I've never seen these in Quash kids, and so it'd be really interesting if we can try and go to different contexts in different countries and try and find these. And again, maybe I wasn't looking, but I never saw this kind of this presentation. So I think it's a really interesting thing that we should try and get people even who are on the field right now to send us pictures.
I really agree with you, Kirrily, because I tried to do a brief ask around globally, just to make my own Kwashiorkor on the map, to ask around, and in some areas people do not see these skin changes, and I suspect that they might be more sub-Saharan specific skin changes, these ones. So yeah.
Thanks. I encourage the person who asked to follow up with you. We will share everybody's emails if there is need for clarification. I think we have time for one last question. So that would be for you, Mary, because it's a little bit more general and you know, conclude maybe very well what we discussed today. So before we focus on edema as a diagnostic criteria, does that cause a bias that we ignore the other features, and how do we encourage a more diverse view?
It's a little difficult to understand, to answer the question if it causes bias, because we don't have the data, and that's partly what we want to do is to get the data. What are the progressions? What do we know? What do we not know? How relevant these are? What is the progression? But I do believe it does tend to bias attention on edema. Definitely what we measure, we pay attention to. What we measure, we have data on, and we know more about. It's like the MOAC, because when MOAC made it much more, much easier to measure a child, and it can more widely spread measurements and things like that, then we see the edema starting to be ignored a little bit, or not giving the attention that it might have had otherwise. But I would say the more we can encourage recording these other signs during surveys. It only takes a second, really, to take a look at the child, to look at his skin, look at edema in other parts of the body, his hair, all these other signs. It only takes a second to do that during a survey. If we could do this more widely, we would have more data on these things, and we could maybe have a better understanding of how Kwashiorkor progresses and how that relates to things like morbidity, mortality, and the final outcomes during treatment. Back to you, Alex.
Thanks a lot, Mary, and thanks a lot really to all our panelists for their great presentations and also answers and reactivities to the question. It's not easy. So we are just about out of time. So I will wrap this up. We have one more webinar coming up that will look at different aspects of Kwashiorkor. If you missed the first webinar, you probably regret it, having heard this one. But don't worry, because you can view the recording on the Feinstein International Center's website with the videos. And that will be the same for this one. So if you want to stay involved and if you want to hear more about the upcoming Kwashiorkor webinars, follow the Feinstein International Center's Twitter. Mary, if you can just put the end slides with all of this. Thanks. So the information for both is on the bottom of these slides. If there are questions that we did not get to, please send them over to me or to the relevant person directly. In the next slides, you can see my email address and the email addresses of the panelists on the slide. So as a follow-up, as I said, we will share the webinar recording as soon as it's ready. And when you leave the webinar, you will see a very short survey. It's really, really short. It takes 30 seconds to answer, and it will pop up on your screen. Please take those 30 seconds to answer the one question, even if you're 1 minute late to your next meeting. I'm sure a lot of you have to jump to another one, which is a new international sports in our field. So this concludes our webinar for today. Thanks a lot for your participations. Even though I know we couldn't hear your voices, but great questions on the chat. I noted more down, and we will see how to address them. We will have a chat with this with all the panelists. Thanks again, and please answer the survey, and talk to you in the next webinar. Bye.